Hello everybody, my name is Richard Xia, and today we'll talk about stress testing. We'll talk about indications for stress testing, angina and probability of coronary artery disease, different types of stress tests, and which to choose. So a stress test is done to look for CAD in patients who are at intermediate risk of acute coronary syndrome, assessment of chronotropic competence of patients, as in if they could increase their heart rate when they exercise, or evaluation of exercise-induced symptoms like patients with aortic stenosis, and assessment of response after medical or surgical interventions in patients with valve disease, arrhythmias, or other heart diseases. So these are some major indications for a stress test. Next, we'll talk about what is typical angina. It is defined as having all three of the following symptoms. So have the patients got substernal chest pain or discomfort. Discomfort or chest pain is provoked by exertion or emotional stress, and it is relieved with rest or nitroglycerin. While atypical angina has two of the three characters above, and non-anginal chest pain may have one or even none. Next, I want to talk about this chart, which shows the pretest probability of coronary artery disease. So in patients with high, that's about greater than 90% pretest probability, intermediate is from 10 to 90, low is from 5 to 10, and very low is from less than 5%. So this chart here, on the left side, we have the ages going down, and on the right side, we have the type of angina. So we got typical, here we have atypical, and non-anginal chest pain, like these that we talked about before. So here, as you can see, as the patients get older, they have a higher pretest probability of having coronary artery disease. And as the patients have less of the anginal symptoms, there's a lesser pretest probability of having coronary artery disease. And also, if you notice, comparing males to females of the same age category, males have a higher pretest probability of coronary artery disease. So this chart is applied when we want to stress the patients, and you want to stress the patients when they have intermediate pretest probability of coronary artery disease. So you determine that the patient needs a cardiac stress test. But what kind of test do you order? We have a stress test with EKG, we have a stress test with echocardiogram, and we have stress tests with nuclear medicine. And these nuclear medicine also stands for myocardial perfusion imaging, or MPI study, and that can be done with the SPECT or a PET. So some general rules to follow. If the patient can exercise, then you go ahead and do the exercise stress test. And also you have to look at their EKG. If the EKG is not normal, meaning if they have some ST changes or LVH, you have to add on some sort of imaging, like an echo or MPI. But they'll still be doing the exercise. And if the patient cannot exercise, then you will have to do a pharmacological stress test. And if a pharmacological stress test is used, you have to add imaging. And choosing what type of pharmacological test agent depends on the underlying comorbidities of the patient, or they have AFib, etc. You want to avoid adenosine if they have COPD, avoid dobutamine if they have like crazy arrhythmias like ventricular, atrioventricular tachycardia or refib. And in terms of choosing an image modality, as an echo or the nuclear imaging, it depends on the institution. You also make sure that you want to compare it to a prior study. So if the patient had an echo before with the stress test, you might consider repeating the same thing with an echo, so you can compare it. And if they want to gather some other information like valvular disease, which an echo will show you valvular disease, whereas nuclear imaging will not. Next, I just want to go through the flow chart, which summarizes what kind of tests to order. So here you have a patient that requires a cardiac stress test, and you want to ask yourself if they're able to exercise. And yes, they are able to exercise. So you do an exercise stress test, and you look at their EKG. If it's completely normal, you go ahead, do the exercise stress test with an exercise EKG. But then you got them on the treadmill, and then they really can't exercise that well, and if the EKG quality was poor, then you're going to have to redo the test with a vasodilator stress test with MPI, so therefore nuclear imaging, a SPECT, or a PET. And if their EKG is abnormal, but they could still exercise, then you want to look what kind of abnormality is on EKG. If it's got LVH or ST changes, you could go ahead and do an echo with the exercise. But if the EKG's got left bundle branch block or other abnormalities like V-paced, AFib, or WPW, you will have to make the patient go through a vasodilator stress test with an MPI or a SPECT and PET. That will not be an exercise stress test anymore. And then here we're going through down this flow sheet. If they're not able to exercise off the bat, you have to go ahead and do a pharmacological stress test, and you want to assess their comorbidities, if they have COPD or AV blocks or sick sinus syndrome or hypersensitivity. Then you can use like vasodilators such as adenosine. So if they have that, you want to think about using a dobutamine for it. But if they don't have those, you can either use a vasodilator or dobutamine. And then you want to look at the EKG again. If the EKG does not have any of these, you can go ahead and do an echo with the pharmacological stress test. But if they do, again, have these abnormalities, you want to go ahead and do this MPI SPECT/PET like we had up there. So lastly, I want to talk about the Bruce protocol for exercise stress testing on the treadmill. So for the goal heart rate, we want to reach about 85% of the maximal predicted heart rate, which is 220 minus the patient's age. And that's an adequate measure of adequate diagnostic exercise stress testing on the treadmill. So here's the standard protocol. It ranges from stage 1 through 7. And here we got miles per hour, meaning how fast the patient is going. And the gray percent is pretty much the percent tilt that the treadmills has. And this tells you how much metabolic equivalence each stage is at. So obviously, higher the metabolic equivalence, better the prognostic factor for these patients. So here we got, here at stage 1, gets like 1.7, slowly increases, and same thing with the grade here as shown. And each stage we have the patient go for 3 minutes. And this is my reference. So if you thought this video was helpful, please like, subscribe, and watch out for my next video. Thank you for listening.